Today's class is on trauma triage. The NR lesson plan wants us to compare the CDC's trauma plan to our own and have a discussion of the CDC's version. We will quickly cover the CDC's version, then focus on our system. The whole point of triage is to be fast and accurate, and it's way easier to accomplish this when it's a simple plan to remember and put into practice. Triage is one of the most critical EMS functions during a mass casualty incident. In our system, we use RAMP. We will get into RAMP soon, but it's important to understand how we got here first. The CDC has no recommendation on a national triage system, but rather uses basic suggestions on assessment. Their use of getting vital signs such as a GCS, a blood pressure, or respiratory rate, assessing the injury, meaning that the more unstable the traumatic injury, the higher priority will be placed on transport, and determining mechanism of injury such as having a set criteria such as fall height or vehicle telemetry data. Also taking note of any special circumstances waste time. Is difficult to remember and relies too much on thinking things through. This doesn't work and needed to be changed. And so the CDC found that studies on triage are difficult to perform, and there really isn't one system that is effective enough. They came out with suggestions to implement, such as making sure that any system used was easy to use in austere environments, easily remembered, and does not use numbers or vital signs. Some of the old systems that we used to use are START and JumpStart, and also SALT. Some of the flaws of these are that they are still too complicated, use respirations, use numbers, and focus on things like capillary refill or global sorting. So after some decades of studies and pulling from some of the best systems globally, the RAMP model was made. The RAMP triage model gives you a structured, evidence-based way to make rapid, life-saving decisions when resources are limited. RAMP stands for Rapid Assessment of Mentation and Pulse. It's a simplified, evidence-based triage method that can be performed in under 30 seconds per patient and uses key physiologic cues to categorize victims. Unlike some older triage models, RAMP is designed for speed and accuracy. Fewer steps, less equipment, and immediate categorization. We are not taking vital signs and making decisions based off numbers. We are seeing if the patient is breathing or not, if they can follow commands or not, and if they have a pulse or not. Simply as that. The science behind RAMP is simple. GCS correlates with direct hospital discharge and trauma. The only problem with this is that we are terrible at accurately scoring GCS on scene, me included, and we basically do this after the call while we're writing our report. However, for RAMP, we are just concerned with the patient following commands. No score is needed. Next is lack of radial pulse. In studies, shows a 92% mortality rate. If they have a radial pulse and are able to follow commands, then they have a 95% survival rate. Besides the science, RAMP is rapid, easy to use, can be taught quickly, and involves no critical thinking. Here is the algorithm. You will notice right off the bat that there is no yellow color patient. As providers, we are very inaccurate at the yellow classification. So all we need to have is the green, red, and black, which is deceased or expectant. In addition to the RAMP model that our medical directors added is the life-saving interventions red box. They want us to be able to perform these interventions if we have the resources and the time available to us. So if we can complete these tasks quickly and move on, then we can save the patient some time by quickly performing an intervention. These are limited to stopping massive bleeding, opening an airway, or doing needle decompression of the chest. After this, we move on to following commands. This is very simple by just asking them their name and requesting that they follow your finger or lift their arms into the air. We then know if cognition is intact or not. Next is radial pulse. This is a sign that they are perfusing enough if they have a radial pulse. So if they follow commands and have a radial pulse, then they are green. If no radial pulse, then red. If they do not follow commands and no radial pulse, then they are expectant or deceased. It's important to note that the pediatrics, the only change is that we will check a brachial pulse instead of a radial pulse. Again, our medical directors added the life-saving interventions. This needs to be done quickly still, 30 to 60 seconds, then you move on. This is only if you have the resources and the time to do this. Airway is maybe positioning or placing an OPA MPA. Bleeding is controlling major bleeding with the tourniquet. Breathing is applying an occlusive dressing or needle compressing the patient, and considerations are maybe placing the patient in the recovery position so that you can move on and come back later when there's more time, but at least you bought them some time. It's important to note as well that with this system, you'll have some pretty sick greens. This is a consideration as well. Reds will go to the hospital first, but then there will be greens that will need to be prioritized and need care before other greens. As we quickly move from patient to patient, we will flag them with their color according to the algorithm. We do not want this to impede our care, but should be used when you can. Next, we move on to more detailed system with Pulsera. This will have all the patient information that we can put on here with the patient destination included. This allows us to identify where patients are going so that if a parent or family member came to us afterwards, we can tell them where their child or family member was transported. RAMP is designed for simplicity and speed. No need to take vitals and try to figure things out. RAMP is a proven system that gets patients to the hospital faster in a more accurate way. Remember that life-saving measures are added, but only if time and resources are available to you. So you get to decide if you have enough people to accomplish this. We should always have more people coming to assist us in an MCI, so maybe you move quickly flagging patients. Then when you get more personnel, you go and perform those life-saving measures. I'll leave the algorithm up so you can all discuss what you might like and not like about this. Discuss what can go wrong and how to overcome these. Discuss how to quickly perform life-saving measures and what might happen if you get stuck treating too much. What do you think about no yellow color code for patients? And have fun, and I'll see you on the next one.